All right, great. Welcome back, everybody. That was a great talk. I know some of these IP talks run over, but I feel like it's so hard to cover these topics in such a short period of time. Our next one is sort of an update on IP in 2025 and many of the procedures that they do, and this will be given by Dr. Folk.
Thank you, Dr. Frank. So without further ado, these are my conflicts of interest. At one point or another, I have been a consultant for a variety of companies in the space of interventional pulmonary. Hopefully, this will not result in an overreach, as you can see in my slide, but I just put this for your consideration. My most important conflict is that I'm the author of a book on pleural diseases that makes an excellent a birthday gift and anniversary gift. So consider that after my talk. Having said that, I asked ChatGPT and open evidence for what is the most important stuff to cover, and I used their guidance. These are the topics: advanced diagnostic techniques for lung cancer, including robotic bronchoscopy and biopsy techniques, advanced imaging, which I will also cover, minimal invasive treatments that you masterfully have seen Dr. Kier present, and the use of valves for advanced emphysema and persistent air leak, which will be covered by my partner, Dr. Keys. Competency-based medical education and the fact that the ABIM is considering the body of knowledge of IP as a subspecialty for 2026. They're considering this possibility. And finally, translational research and novel therapeutics in intratumoral therapy and ablation. And I will try to cover the brief and small research we're doing on this. So with that in mind, if you're going to pay attention to only one of the slides, this is the spectrum of interventional pulmonary. And I keep increasing the mind map for your consideration. But on the left, you see in blue the pleural procedures Dr. Kier covered, percutaneous tracheostomy that is shared by many specialties, bronchoscopic approaches that include flexible bronchoscopy, EBUS, ultrasound-guided percutaneous biopsy, navigation, whole lung lavage, bronchial thermoplasty, valves, robotics, delayed ablation, rigid bronchoscopy, advanced imaging, and on the esophageal procedures, PEG placement or gastrostomy tube placement, EUS, diagnostic esophagoscopy and staging, as well as the treatment of T fistulas. So this is the breadth of IP, and I'm going to try to do it justice in the next 37.5 minutes. So I'm going to use a few case-based just to show you that it is not a technology-based, but it is problem-based and how we approach this. This is a patient who presented to our clinic with a very small pleural-based nodule in the right upper lobe. And as you can see here, the two structures nearby are the trachea and the esophagus. So we had to make a dedicated approach to this and say, how do we approach it? We can go around the airways and do a navigated bronchoscopy, or we can just choose the closest structure, which is the esophagus. But before I show you what we ended up doing, these are the considerations in the minds of your advanced bronchoscopist or interventional pulmonologist when we approach this. On the left, the considerations about the patient condition, what are their comorbidities, performance status, and pulmonary function testing, but also the probability of malignancy, the feasibility of doing a biopsy, right? Including the risk, the yield of that procedure, but most important, the human and technological capital. You can spin your wheels for a while, but if you don't have the technology and you don't have the training, some of these nodules and some of these lesions are hard to address. And finally, the most important key performance indicator for me is timeliness. How fast can you contribute and add value to this patient? Nobody wants to hear that they may have cancer or may have tuberculosis, etc., and or invasive fungal infection and not address it in a timely fashion. Now, on the right side, you can see that the diagnostic modalities can be somewhat compartmentalized, whether the lesion is central, it's peripheral, it involves the mediastinum, or it involves pleural fluid. And of course, our approaches vary both from the bronchoscopic perspective as well as the pleural perspective or the surgical perspective. So with that in mind, the take-home message is any lesion that is concerning should be imaged appropriately, should be biopsy. If it's malignant, should be thoroughly staged, not only with imaging, and should be treated accordingly in a timely fashion, if I can emphasize that. So with that in mind, it's important to understand the difference between having a resected sample in yellow here and a small biopsy. If you obtain a small biopsy, you have three tasks. The first one, is it malignant, yes or no? If it is malignant, immunohistochemistry should guide you whether this is a squamous versus non-squamous versus a neuroendocrine profile. And finally, the driver oncogene should be determined and consider that the probability of a driver oncogene presence is inversely proportional to smoking history. In other words, if the patient has an extensive smoking history, the probability of having a driver oncogene is dramatically decreased. However, the pipeline is wide open and our oncologists are producing incredible results. So we need not be complacent and give them as much information as we can. Now, with resected samples, you can talk about adenomatous hyperplasia, adenocarcinoma in situ, minimal invasive adenocarcinoma, or invasive adenocarcinoma. And like I said, we provide enough information for molecular testing, and the resected sample provides you information about involvement of the visceral pleura or the lymphatics or large vessels, etc. With that in mind, going back to our patient that we suspected malignancy, instead of using an approach through the airway that pulmonologists obviously are biased towards, in this case, we decided to go through the esophagus, and we use fluoroscopy and ultrasound to biopsy the lesion, as you can see here on ultrasound, and we obtained a diagnosis of tuberculosis. What I didn't tell you is that this young woman in her distant past had been a microbiology tech during college. So she had exposures, but fortunately this lesion was very small and we were able to treat her. This was not malignant, so it was a very welcome diagnosis. Now, with that, let me present a different case with a higher probability of malignancy. This is a 78-year-old lively woman with an extensive smoking history, where our colleagues in radiology declined because of the degree of emphysema and the risk of pneumothorax. And so they asked us to participate. You can see it's a pleural-based lesion. However, her clinical consideration was high risk of pneumothorax, high risk of complications of surgery. This is an incidental finding. This was found incidentally, but it's important to separate incidental from screening, where in screening, about 1 to 2% of patients will be found to have malignancy, while if it's incidental, up to 10% will be malignant. Now let's look at these 5 largest screening studies. And it's easy to see the trend. The majority, not the majority, a large percentage of patients, between 13% and 48%, will have an abnormal CAT scan. However, of those large numbers, only a small proportion, between 3 and 11%, will be malignant. But contrary to our immediate thought that this is stage 1 or early lung cancer, a variety of patients, a large number of patients, anywhere between 14% and 43%, will actually not be stage 1. They will be stage 2, 3, and 4, indicating that we cannot be complacent and we need to look at the mediastinum, other structures in the chest, other structures around the body for signals that this has metastasized beyond stage 1. Having said that, the risk is inverse. The risk is inverse to the ease of the procedure, or the diagnostic certainty is inverse to the amount of tissue. No? If you do sputum or BAL, you will have very safe procedure with very low diagnostic certainty, as this slide from Dr. Vanderland shows. However, surgery will give you 100% certainty with significant risk. So we're trying to find the sweet spot where we minimize the risk for the patient and the discomfort while maximizing the information. And in that sense, The first thing we do is we calculate the probability of malignancy. And Dr. Frank will talk more about this, so I'm just going to glaze through it saying, these are the 6 models that are most clinically used around the country. And this paper by Choi and Mazone shows 4 nodules where they had the final diagnosis. The first and the fourth are benign. And what they show is that the different probability models show a variety of numbers. So if the same nodule is graded very different by different models, that tells you that they're not very precise and they're not necessarily better than an expert opinion. So we have to investigate if the probability is intermediate or high, and we have to closely follow if the probability is low. With that in mind, who gets staging? The short answer is almost everyone. Unless you have a lesion that is less than 2 centimeters, meaning it's a stage 1A tumor and no imaging findings that are concerning, then you can get away with a therapeutic approach that involves surgery and resection without interrogating the mediastinum. But most patients will present beyond this stage, and in most cases, we recommend invasive staging with EVOS, EUS, or mediastinoscopy, and I'll show you the difference. We need not confuse pathologic staging with clinical staging. Clinical staging means using imaging, EVOS, EUS. Pathologic staging is only reserved for surgical staging. So when you see in the board test pathologic staging, they're talking about surgery. This graph shows you the complementary fashion of EVOS, EUS, and mediastinoscopy. Mediastinoscopy is limited to the central airways, meaning to the stations that go all the way to the carina, no more. While EVOS and EUS provide you a more thorough staging in the both sides and the hyla and the lobar even. And EUS provides the added benefit of reaching stations 8 and 9, okay? Now, imaging, percutaneous biopsies for staging in the lung are usually not recommended because of the risk of pneumothorax, but also because of the risk that some of the lesions, in this case, this patient underwent a CT-guided biopsy of the center of this PET avid, and as you can see in the PET scan, the center was necrotic. We did not obtain enough information. We should have followed the guidelines of staging using the mediastinum or a distant structure. Having said that, not all tools are created equal. There's a variety of needles, cutting needles, sliding needles. There's a variety of needles and a variety of forceps. And suffice it to say, these 2 innocuous-looking brands of forceps show you that the sample to your view on the screen, the samples are different in size. I cannot say that they are different in quality or interpretation, but what I can tell you is usually more tissue is better, but I just wanted to show you because one of the ways to improve your yield is just to use larger or better quality instruments. Having said that, how you process the sample is incredibly important, and our colleagues in cytopathology have developed an art of this by using our samples, spinning them, turning them into a cell block, and treating them like histopathology samples, and that has translated into incredible outcomes. So I'll show you a little more about that, but very important that you're familiar with these tables from the guidelines on lung cancer staging that show the sensitivity of PET-CT 62% with a specificity of 90. In other words, you're going to be wrong on making the diagnosis and on excluding the diagnosis, so don't be complacent on imaging. In comparison, mediastinoscopy, that for a long time was considered the gold standard, has a sensitivity of 81% that is only surpassed by needle techniques, EUS and EVOS. And how about if you combine EVOS and EUS, your sensitivity goes up to 91%. So keep that in mind. Now, when we obtain tissue, is needle, forceps, or EVOS better? Well, at least in this study that we did a number of years back when driver oncogenes were relatively new, the CT-guided biopsy provides you these islands, as you can see, of tissue. The transbronchial biopsy gives you larger samples with, again, this clearly visualized areas of tumors, while the EBUS provides you a random sample of the lymph node that we summarize in this spun, and we call it a clot. It's not a clot, but you can see that there are innumerable number of islands of malignancy. So when we looked at this critically, we found that the EBUS and the surgical way of obtaining surgical samples were not statistically different. And the transbronchial biopsy, not statistically different. However, the CT guided was inferior. And the reason it was inferior, at least for driver oncogenes, was not the sampling, it was the decalcification of the sample. So keep that in mind when you revert to doing a bone biopsy. If you want to do a bone biopsy, know that it's likely you will lose some material. With that in mind, that's one study. How about meta-analysis? This is a meta-analysis that we published with 2,700 patients almost on EGFR, looking at 33 studies. And what we found out was that the performance of EBUS for providing driver oncogenes was almost 95%. And how about for PD-1, PD-L1? The EBUS samples were appropriate in 98% of the cases, insufficient in 2%. How about if you do PD-L1 by immunohistochemistry, another method? We found EBUS samples to be deficient in 4%. So the answer is, it is very reliable. The more you do it, the better you get at, but very important that we have good communication with our cytopathologists. I get questions every year about liquid biopsy. This is the guidelines from 2018 from ISLAC have not changed. The liquid biopsy should be used in cases in which you cannot obtain tissue from the patient, or rebiopsy in cases in which rebiopsy could not be done due to the clinical condition of the patient. I don't have to say that the person determining if the patient is or is not a candidate for a procedure should be the proceduralist, right? It may be convenient for oncologists or primary care to order a liquid-based or blood-based sample, but the reality is that their performance is poor in terms of early lung cancer or a recurrence of early lung cancer after treatment. So it is better to go with tissue biopsy, and this is based on guidelines, not my opinion. Of course, my opinion is that. How about lymphoma? I get questions about EBUS and lymphoma. Lymphoma, if you don't suspect it, our performance is inferior. In other words, our sensitivity, if you don't suspect lymphoma, is close to 67% if we don't send it for the right tests, while recurrent lymphoma, where our suspicion is significantly higher, is 77.8% in this meta-analysis. But you can see here in this forest plot that one study is very negative, but the majority of studies are significantly better here on the right side of this forest plot. Now, going back to that patient that I showed you with the peripheral lesion that was very scary, we did a navigation bronchoscopy using traditional bronchoscopy and electromagnetic navigation called SuperD. And we obtained the diagnosis in the anterior pleural base lesion. This is a study now, it's dated 2018, but I show it to you because these bubbles represent a variety of electromagnetic studies that have been done, and most of them were retrospective, some of them were prospective, and finally Navigate did a study on a very large number of patients showing the yield to be around 73% at 1 year. Since then, we have perfected or suggested better definitions for lung biopsy results, but I just want to give you the variety of results you see indicate that these were not studies that were multi-center or were randomized. However, randomization is not the solution to this, because remember that we're talking about something that requires human capital. And if the provider who's doing it is not very good at one technology or another, that completely biases the results. So what we need is what cardiology does, very, very large studies in a variety of settings, right? And that's what Navigate did, but not in a comparative fashion. They did it in 23 centers around the world. I'm sorry, 27 centers around the world, but it was not randomized fashion. The pneumothorax rate was also in different studies showed between 0 and 13%, and this variation indicates that human capital is incredibly impactful on these studies. Now, this dwarfs in comparison with CT-guided that has 25% pneumothorax rate and 15% rate of chest tube placement. This is literature published by IR, not by me. However, when we do bronchoscopy in COPD patients and we're concerned about their complications, this subgroup of Navigate shows you that there was no increased complication rate if the patients had severe emphysema if you do this bronchoscopic. The rate in early bronchoscopy by FEV1, so mild bronchoscopy was 11%, while moderate was 9%, and then severe was 13%. These were not statistically different. Now, if you analyze emphysema by DLCO, you saw a trend, but it was again not statistically different, indicating that bronchoscopic biopsy in emphysema is safe. This is a meta-analysis and systematic review, so you don't take that one study. And we found in 40 publications that the sensitivity for malignancy of electromagnetic navigation up to 2019 was 77% with a pneumothorax rate of 2%. All of this is in your slides, so I'm sorry if it seems like I'm rushed, but I'm trying to get through everything. Now, when we navigate, and this is the present and the future, when we navigate, we like to summarize the diagnostic in, is the robot or is the navigation positive or negative? But that's a summary of something that is quite complex. The robot only participates in the planning and the navigation. The real-time confirmation and the tissue acquisitions are additional technologies that we add on to the process. So when you read studies about the diagnostic yield of one technique or another technique, keep this in mind. We're trying to oversimplify something that is complex. And complex because of the final outcome is not yes or no. It's a probability result. And number two, because it's done by a human who may be having a good day, a bad day, or a late day. So in the planning, we have to have a recent CAT scan with good airway segmentation and with appropriate number of slices and overlap. In the navigation is where these devices actually play a major role, making the right decision on every carina and helping us to reach the target in the periphery if they're small enough, meaning the catheter is small enough. The real-time confirmation is virtue of real-time imaging, whether it's CAT scan, digital tomosynthesis, or radial EVAs. And finally, the tissue acquisition depends on two things: the type of tool you use and the expertise and confidence of your cytopathologist. So in this mind map, I show you the leading technologies for navigation. There's 4 leading technologies. 3 of them are in electromagnetic. One I showed you, the Super D, I showed you the numbers. It's a fixed catheter device. And after years, they actually coupled it with imaging called digital tomosynthesis. And this is called Illumicide when they're combined. Then the robots, the first robot to come to the market was a Monarch with a mother-daughter configuration. And then just recently, they received FDA clearance, not approval, I'm sorry, 2 different concepts. They received clearance in 2025 for integration with Conbeam CT. And finally, Galaxy, that was approved on March 2nd, 2023, and it is a combination of digital tomosynthesis, augmented fluoro, and robotics. This is very early. It's meaning there's very few results published. I'll show you what's published. And finally, the shape sensing technology that is different than electromagnetics is the ion, and it's integrated with Conbeam CT, as I will show you next. And this is completely different to electromagnetic navigation. This is shape sensing. The catheter of the shape sensing robot has innumerable number of sensors that transmit this to the software. But not only that, the catheter has a fiber that is formed of innumerable crystals, and the crystals transmit light at the speed of light. However, if you remember, the only way you can change the speed of light is if you actually block it or you change the medium in which it travels. So what they did is, this is a NASA technology. What they did is they put these crystals next to each other, and when there's a flexion of the catheter, there's a tiny little delay in the speed of light, and that's how the system reads that there's a change in location. So that is what shape sensing actually means. It's a delay in the travel of the speed of light. This is a publication from a few years ago, but I just want to show you that the safety of these robots compared to percutaneous biopsy is at least tenfold. In other words, no matter these two robots, the Monarch or the Ion, when you tested them, their rate of pneumothorax was between 1% and 3%, while in comparison, 15 to 25 for our percutaneous approach. Now, this is not that every navigation technique is as safe, because Thibodeau and Yarmos published a year or two ago their experience with Veran that showed a 34% pneumothorax rate. Suffice it to say, Veran is out of the market at this point because they have a higher complication rate than a percutaneous biopsy. Regarding yield, the yield is difficult to make it uniform because these are different techniques, and as I said, in the hands of different people, but you can get an idea that the yield is between 82% and 88% if you use regular fluoroscopy and shape sensing, and it's between 67 and 77% if you use the Monarch with regular fluoroscopy. Now, the groups of patients that they apply this to is diverse in size and complexity, and for that reason, I put this table to show you the size of the nodules that they included in this series. The only publication I have on NOAA Galaxy, the integrated robot that I showed you with digital tomosynthesis, has 19 patients, and when 19 nodules in 18 patients. When you have such a small sample, everything gets magnified. And what they showed with nodules that are large, this is 20 millimeters, this is now large, they showed an 89% yield with their own diagnostic yield definition and an 11.7% pneumothorax rate, which is, in my opinion, high compared to the other options that we currently have. But until we have new data, this is what I have to go by. They publish, I understand there's a paper coming out in the next 30 days or so. How else can you get better? Dr. Oberg published this very interesting study in UCLA showing 120 consecutive cases, and what she did is just use the regular C-arm using shape sensing robotics, but changing the tool. And when she changed the tool, she demonstrated that 90% diagnostic yield, which is in the level of CT guided biopsy, where only 18% of the cases were diagnosed with cryobiopsy. In other words, the delta was provided to become very, very competitive by the cryobiopsy because it provides a larger sample and a higher quality tissue. So keep that in mind as your interventional pulmonologist or advanced bronchoscopist recommends a cryobiopsy of a peripheral nodule. This is what they're talking about. Regarding imaging, this is a simplification of the 4 techniques we can use, and they go from a lower complexity to higher complexity and lower cost to higher cost in acquisition, meaning to buy the hardware, not to perform the procedure necessarily. So in the first one, 2D fluoro, we all have it, and tried and true, excellent results. The second one is digital tomosynthesis, in which the C-arm, any C-arm, is rotated 30 degrees one way, 30 degrees the other way, and a software creates a algorithm, or has an algorithm that creates a pseudo 3D nodule, that tells you the location and the size there at the time of the procedure. But it is pseudo 3D because it's based on assumptions, and you're not getting a 3D. And finally, the mobile cone beam CT and the fixed cone beam CT are CTs that provide you true 3D images in axial, coronal, and sagittal. The fixed one, to give you an idea, in the US, this is $350,000 the machine. Well, this is $2.5 million and requires a special room and special techs. So there's a big jump between these two. And what you get added here is obviously this is the gold standard, but you get added this avatar or this little figure that tells you you're on the target. It doesn't tell you that. It gives you some confidence, but it's a very good reminder. I'm not sure if a tenfold or eightfold increase in price is justified, but feel free to investigate further. What I'm going to say is if you do ablation, you need cone beam CT. There's no ablation in these two platforms. It's too imprecise. Regarding radiation, this table is for your later consumption. I just want to show that if you compare a CT-guided biopsy, which usually provides about 7.1 millisieverts of radiation to the patient, and you compare it to a cone beam CT-guided bronchoscopy, which is between 1 and 2 millisieverts, you can see that these procedures are not particularly dangerous in terms of radiation. Now, we all want to do the minimum possible radiation, but for the provider, for us, the most important thing is distance. We need to step away 6 feet, at least, if not leave the room. And we have to use lead that decreases the radiation significantly, of course. But for the patient, we use the lowest possible radiation. Just be reminded that a right heart cath is about 9 millisieverts, and your annual radiation, just for being on Earth, between radon and being on Earth and the sun, it's about 3 millisieverts. So we're not talking about prohibitive levels of radiation in all of this. With that said, this other table summarizes some of the characteristics that I've already mentioned about chest X-ray, digital tomosynthesis, augmented fluoro, and cone beam CT for your later summary. These are the two mobile cone beam CT units available in the market, the one from GE and the one from Siemens. And I'm going to show you a quick example of a recent lesion that we saw in conjunction with Dr. Frank, who will be talking about nodules. But you can see this lesion in a patient with severe emphysema, has a central calcification, and it's in close proximity to the pleura, with tethering the pleura and tethering the aortic arch. So our concern was that this was behaving in a malignant way. Of course, the patient's characteristic had prompted long-term observation. They started small, but had a central calcification. And as we watched the patient, our degree of concern increased and increased to a point where we said, you know, we have the technological and the human capital. Let's go for this. And just to give you an idea of the patient's degree of lung destruction, the DLCO was 28%. So it's not something that we would jump right into resection, right? With that, the central calcification should be a point for your exam if you're taking the board, in which these are the benign patterns of calcification. And you can see here 3 examples of the diffuse, the central, and the popcorn or laminar, all of them benign patterns, but they are not 100% predictive. So keep that in mind in your practice. So we went through the esophagus, we did a biopsy, and the pathologist told us it was aspergillus. This did not satisfy our pretest probability, so we quickly shifted. This is the EBUS lesion. We quickly shifted to planning the navigation in this case, and you can see here that this is the plan you do with the CAT scan. Looks more like a video game, and this is an actual 2-minute video that I'm going to narrate quickly, but you have to, at the time of the procedure, you have to tell the robot what's the right and the left. You can see here a clock at the top that tells you the exact time. I accelerated the video, but you can see the time that it takes us to do these procedures. These are seconds, minutes, of course. Once you show the robot what the right upper, left upper, left lower, and right lower are, the robot overlaps your planning, the planning you did in advance, and it's shown in this blue line that I'm going to follow now. You can see that was 1 minute and 50 seconds to do the registration, and then I navigate to the left upper lobe location that is above the aortic arch. You can see that the airways keep getting smaller and smaller, and our 3.5 millimeter catheter advances to the periphery carefully. We reached a point in which we felt we were stuck and we didn't want to advance because the aorta is there, as you can see in this pulsation. We stopped there. We advanced the radial EVAs. We got a signal in the radial EVAs, and we said, oh, we're in the right airway. So we advanced the robot to that location. And just for, again, that confirmation, I can't miss. This is high probability. We have observed this patient for a while. We have done the EUS, and we didn't get the answers we needed. So for additional confirmation, we did a cone beam CT, and you can see on this image, in this coronal image, the robot arm is here, and the needle is right in the center of the lesion. This showed to malignant cells to our cytopathologist, and once immunohistochemistry was done, this was found to be a neuroendocrine tumor. It was not as easy as we all expected. Now, can we correct for CT to body divergence? And what is CT to body divergence? Is the fact that patients get a CAT scan in a resting position with arms up. And when we do full inspiration, and when we do the case, the patient is ventilating at a lower FRC, and the nodule or the lung can move proximally. And what we use is this integration between the robot and the cone beam CT, and I'm going to show you how fast this is done. The robot has the prior CAT scan. When we obtain the new CAT scan intraprocedurally, we tell the software of the robot, hey, this is the nodule now. This is the location of the nodule on the new CAT scan. Please adjust my planning accordingly. And everything gets shifted, and we call this integration. And as you can see, the position and location gets moved from this initial location to that location that you see solid. These are the three brands of fixed cone beam CT. And in the last, this is the future of cone beam CT. This is in the museum or in the training facility of Siemens. And you can see that this is incredibly powerful to us, especially in the next area of ablation. But we have to do this as fast as we can. And what I want to convey to you is that getting all these specialists and the primary care cardiology clearance and ancillary testing in a timely fashion is what we need to be focused on. Some people, like me, thought it was related to who gets paid and what they get paid, but this data from single-payer system countries shows that they have similar delays to the US. So in the US, it takes 5 to 6 months in average from identification of the abnormality to treatment, and that translates into upstaging. So we need to do better, and it is not only a financial reason, because as you see, single payer, they have a delay, a fee for service, we have a delay. We need to do this better and have better coordination. We can also provide our oncologists with a tissue for recurrent disease or residual disease, so they can actually target their efforts. I want to show you the rest of IP briefly. It hasn't changed much in a number of years, but this is a case that we saw last year, 59-year-old smoker presenting to the ER with almost complete obstruction. And in coordination with our expert anesthesiologist, we took the patient to the OR. We saw that there was a significant, we confirmed the obstruction that was evident clinically and radiologically. And we decided to advance a catheter to oxygenate distally. An option here, some people would say, let's do ECMO. The moment you press the ECMO button, you've made a decision to spend approximately $300,000. So I'm not fond of that, so I don't use it much. But what we do is we classify the lesion and we plan, is this an intrinsic, extrinsic, or mixed? And then we tailor what we're going to do about that. And in this case, as I'm going to show you here, we advance a catheter, oxygenated distally, and had a balloon if we needed it. And then we chose thermal therapy to ablate the tumor and then remove it bronchoscopically, later to place a stent, a custom-made stent with silicone. And this is the final outcome. This is the beginning. This is the final outcome. The patient received a diagnosis and treatment, and a month later, they came to see us, and you can see the stent is in place. The tumor has been ablated between us and radiation and chemotherapy. We've made incredible improvement, and now we can remove the stent because it doesn't have to protect the airway anymore. Now, this is plumbing, but it is plumbing that is applied very often to our patients. So I'm going to bypass the rest of these slides for your consideration. I want to use the last 30 seconds to show you what's in the future. So something about competency. Competency-based versus number of cases. This is the new hot topic on training. I have to say, I'm biased. I think the number of cases, like the number of flight hours for a pilot, are important. And the mastery comes with number of cases, but also with competency-based. The last thing I'm going to say is that for ablation, this is a slide showing that ablation is the newest treatment for lung cancer, and that we can do it image guided or we can do it bronchoscopy guided. We are doing the clinical trials for that. And I just leave you with the NCCN guidelines are including now local ablation for lung cancer, and we're doing the necessary studies in order to bring this to you. I'm sorry if this feels rushed. I will bypass the esophageal procedures, but I will. The slides are self-explanatory. And with that, these are the two members of my team, and we are here if we can help in any way. We'll answer questions a little later. Thank you so much for your attention.